All right, welcome to the HIV TB Echo. It's 14:30 on the dot, so we are starting now. I would like to welcome all the participants for today. Kabwata Urban Health Center, you're welcome. Thank you for joining. Chezia Sakala, you're welcome. Thank you for joining. To facilitate today's session, I'm Dr. Peter Matibula, joining you from the hub at UTH. In the hub, I'm also joined by our didactic presenter for today, Dr. Chikumbi Chambwe. I'm also joined by an expert, Dr. Naim Dalao, and our very able IT personnel, Chatonda and Nikoi, and also joined by our coordinator for the HIV-TB Echo, Etambuyo. Right, so like I said, the expert presenter for today, the didactic presenter, is Dr. Chikumbi Chambwe. Just a reminder before we go ahead, colleagues, on echo etiquette, let's remember to mute our mics if we're not talking, and whenever we join, we keep our mics muted unless asked to unmute. Just a brief recap on the session that we had last week, Monday. Last week, Monday, we looked at cervical cancer screening and prevention. And we noted that the tests that are used for screening really include the HPV, DNA tests, the cytology, and also the VIA. There was a specific focus on screening in people living with HIV because we know that cervical cancer is more prevalent in people who are living with HIV. And we noted that in terms of how often the screening should be done for cervical cancer, if we look at the general population, those who do not have HIV, it's recommended that the screening should start at the age of 30 and stop at the age of 50 after 2 consecutive screening tests are negative. And how often you screen the general population? It's 5 to 10 years. But coming to the people living with HIV, we noted that the age of starting to screen should be age 25, and you stop at the age 50. Of course, when you have 2 consecutive negative screening tests. And in terms of how often you screen, people who are living with HIV, it's different with the general population. Those should be screened from every 3 to 5 years. Okay, so today we are looking at another topic, which is leveraging on CETA to improve clinical outcomes in HIV care. So like I said, our didactic presenter for today is Dr. Chikumbi Chambwe. We're also joined by a panel of experts. Yeah, welcome. We're joined by Dr. Francisca Walia. We're also joined by Dr. Mwene Seluke, Mr. Gabriel Lungu, and also Dr. Angel Chira. So we're going to have a didactic presentation first, and then thereafter we'll have a case presentation from Kabwata Urban Health Center. Thereafter, we'll break out into smaller groups, of which we'll discuss the case further. We'll have an expert collaboration on the case. So at this point, allow me to call upon the didactic presenter for today, Dr. Chikumbi Chambwe, to start with the presentation for today. So I'll just share the slides. Okay.
Yeah, that's the one. This is the screen. The one, that one.
All right, so Dr. Chikumbi Chambwe, over to you. You can start with the didactic presentation for today.
Okay, thank you very much, Doc. Good afternoon, network. My name is Dr. Chikumbi Chambwe. I'll be making the presentation today on leveraging on CETA to improve HIV clinical outcomes. Next slide, please. So for the learning objectives, first, we're going to discuss common psychosocial conditions, people living with HIV. Then we'll describe key strategies to address mental health issues in people living with HIV. Then mental health and ARVs, the interaction, as well as CETA, which will be the last part of my presentation.
All right, thank you for that introduction, Dr. Chambwe. So we'll start with a poll. Right, so the question reads, according to admissions and reviews in Zambia, people living with HIV account for one of the leading causes of mental health illnesses. So indicate whether this statement is true or false. I'll read it again. According to admissions and reviews in Zambia, people living with HIV account for one of the leading causes of mental illnesses. Right, so I'll just give it a few seconds for the network to respond. So far, there's a good response. We have over 50% of the network responding, and the majority feels like, yes, this statement is true. So far, 91% are agreeing that this statement is true. So we'll see with the preceding slides how the presentation will go and the answers to these 4 questions. So allow me to end the poll at this point and actually share the results. So you can see that the majority, 91% of the. So over to you, Dr. Chambwe, reflect on this 4 question as we proceed.
Okay, thank you, Doc. So first things first, we need to discuss about the relationship between HIV and mental health. This relationship is bidirectional. So you can have people who have mental disorders at high risk of acquiring HIV, mainly because of risky behaviors or disinhibited behaviors that they may be doing. And also they are in use of substances and also risky high-risk sexual behaviors, usually associated with people with mental disorders. Likewise, people living with HIV also prone to mental health disorders. For example, they can have depression and also issues of anxiety. So for the bidirectional model that we use, relationship that we're looking at here, we'll look at the biopsychosocial relationship or the framework that we use to diagnose mental illnesses. So the interactions that people have, biological, psychological, social factors that determine the cause, manifestation, and outcome of illness. This is opposed to the different method that we used to use where we just focus on the disease and we treat the client, but now we're looking at the biology, psychology, as well as the social aspects. So for the biological aspect, you have someone's gender, physical illness, genetics that gives the indication of someone's ability to get a certain mental disorder. And for the psychological aspect is the person's life, their experiences and their behaviors and their character. All this comes into play where you have the attitudes, the beliefs, personality, how they cope with trauma and certain skills, their emotions and their behavior ultimately. And then the social aspect, which is the environmental aspect, if you will, what's around them and what factors around them affects their lives. Their social support, the family background, socioeconomic status, culture, traditions, religious norms, as well as educational backgrounds. So all these things put together have an effect on the person's ability or how prone the person is to develop a mental illness. Next slide, please. So this is a small study that was done in Kanyama that shows that 31% of most clients, that most outpatient cases were due to HIV-induced psychiatric disorders, which included mania, psychosis, delirium, as well as dementia. And then followed by a close second, which is alcohol-induced disorders, and further down as illustrated in the picture. So as we discussed in the previous slide, most of the mental health cases are HIV-induced, and the common ones are as follows. We have major depressive disorders, anxiety disorders, adjustment disorders, psychosis, delirium, mania, and dementia. So these are the common conditions that people living with HIV may present with, and this may be caused by different factors, which will be highlighted further on as we go on in the presentation.
All right, so we pause for another poll question. Allow me to launch the poll question. So the question reads, concerning HIV mental health, treatment strategies focus on which of the following? Is it A, mental health screening to be done on initial visit and subsequent reviews? B, suppressing the HIV virus and maintaining optimal ART adherence? C, treating the HIV and mental health separately. And then D, treating the patient living with HIV holistically. And E, is A, B, and D correct? I'll read the question again. Concerning HIV mental health treatment strategies focuses on which of the following? Is it A, just mental health screening to be done on the initial visit and subsequent reviews? Or B, just suppressing the HIV virus and maintaining optimal ART adherence? Or just C, treating the HIV and mental health separately? Or D, treating the patient living with HIV holistically? Or is it that A, B, and D are all correct? Great, so we have good response from the network so far. About 69% feel that yes, A, B, and D are correct so far. Right, so we have 50% of the network, more than 50% of the network responding. So I'll end the poll in the next few seconds and then share the results. So far, no one is going for C. This is a very good sign. All right, so allow me to end the poll now and share the results. Okay, so there you have it. So the majority actually feel that A, B, and D are actually correct. So we'll see in the preceding slides which ones are actually correct, or if A, B, and D is indeed the correct answer. So over to you, Dr. Chambwe.
Okay, thank you very much, Doc. So for this part, I would like to just give some global statistics. And before the statistics, let me just answer a question that has been asked. Why are we concentrating so much on mental health? As WHO defined it, health is a complete state of physical, mental, and social well-being. And then the mental health aspect has been left behind, not just in our country, but globally as well. And it's also important to note that out of the disease burden all around the world, 14% of them are mental health disorders. And 75% of this burden is found in low and middle income countries, which includes us here in Africa and some parts of South America and some parts of Asia as well. And according to the WHO recommendation on how we can manage mental health, in our settings, in our low resource regions like ours, it's impractical, ineffective, and resource intensive to succeed. So we need to have other ways in which we can manage our clients with mental disorders for it to be effective in our communities. Next slide, please. So this pyramid just illustrates the frequency in which we need specialist treatment, as well as the corresponding costs. As you may see in the lower two aspects of the pyramid, the lower aspect talks about self-care. This is just somebody being self-aware about the condition that they may have, and maybe also working on something to manage it. And then there's also informal community care, which also comes from the community. These are all informal services that we come across, of which we do relatively poorly in our country because of the stigma that's attached to mental illness, both from culture and religious aspects. Then we have the primary care mental health services, which we are trying to develop now because our clients come to our facilities, and mental health services are provided at some clinics, but not all of them, and we need to strengthen that. And then there's psychiatric services, that general hospitals and community mental health services, which is weak currently in our country. And then there's long-stay facilities and access to specialist services, which we have Chinama and UTH here in Osaka, of which, as we may know, there's understaffing and the resources are not enough. So the cost is very, very high to see a specialist as the pyramid goes up. And what we need as a country is to improve the informal community care and the resensitization, and also just to improve the base so that we can have our clients being aware about mental health and also getting care as soon as possible. Next slide, please. So for the key strategies, as illustrated in the advanced HIV guidelines, there's level 1, level 2, and level 3. So for the level 1 is the psychiatric care and treatment. Then level 2, we have the mental health services through primary healthcare and HIV clinics. And then the level 3 is a community support programs services. Next slide, please. So we'll look at the entire spectrum of a client who's before they're diagnosed and they start treatment, and then also maybe end of life care. So in the pre-ART phase, there's counseling and testing that takes place. Mostly the issues that come about is issues of stigma, discrimination, and issues of non-disclosure. So network for this part is level 1, level 2, and level 3. As you mentioned, level 1, that's specialist care. Level 2, that's care at the primary healthcare level. Then level 3 is at community level. So for the purposes of being systematic, I'll start with level 3, and then I'll be going upwards to discuss on how we can intervene at different stages to help these clients. So at level 3, which is the community level, we can have programs to reduce stigma, and also post-test peer support groups that can be in the community to make our clients more comfortable and more knowledgeable about the condition. And then level 2, we can have post-test clubs. This can be integrated in some of our adolescent and youth programs, as well as MCH programs as well, can be very helpful. And screening and brief interventions can be done in our clients. For example, if someone has anxiety issues, they can easily be managed at primary healthcare level with CHIPO interventions using different tools. For level 1, this is for the specialists. We have targeted HIV screening with the mental health population, and they'll be treated accordingly. So if we follow these stages, it will be very helpful, and very few patients will slip through the cracks. And then go to initiation of care and retention. The main issues are social consequences, stigma, drug use, as well as alcohol use. Then again, I will start the community support, and recovery groups can be put in place to help. Screening for depression, substance use, and help with adherence. And also for the tertiary aspect, we can have assessment and treatment of mental health and substance abuse problems. Next slide, please. So once the patient is on treatment, please be aware that mental health screening and mental health treatment is a continuous process. And every time we come into contact with our clients, we need to be able to screen them for mental health issues, as we do for other illnesses, especially TB, hepatitis B, and so on and so forth. So for initiation of ART, one of the main issues is access to ART, gives issues of stigma that come into play, and discrimination, and also drug and alcohol use because of their diagnosis. As you may know, some clients prefer getting the drugs in different districts and different towns because of issues of stigma, which I think is a big issue, and also plays a huge factor with adherence. So as we discussed before, we can go to the level 3. We can have community support to help these clients. We can help with adherence, and also continue with the assessments of these clients every time they come to our facilities for mental health and issues of substance abuse. When it comes to maintenance on ART, the main issues that we have are treatment adherence and dropouts, and side effects, and neurocognitive changes. So at community level, we can have mental health services provided by nurses and community health workers that we may train, and they can provide these services at community level, provide IEC, and just open doors to the community on different ways in which they can be managed. Then we can have adherence and counseling, which is very important. It has to be continuous as well. Management of mild depression and anxiety disorders, and also assessment and treatment of mental health and the substance abuse problems as they arise as soon as possible, using this very important cascade that we've developed. Next slide, please. And then there's advanced and end of life phase of treatments. So we can have care for the caregivers. So the main issues that come into play, there's physical decline and increased symptoms of the ill clients, depression and thoughts of suicide, stigma and discrimination. This is someone that's very ill, maybe they're bedridden, and they feel like they're a burden to themselves and to the community, and most of them feel like they want to end their lives. So we can have home care and community-based care to just offer support to these clients, At level 2, we can have palliative care services and psychosocial support, not only to the client, but also to the family and the people that they're in contact with. And if the symptoms are very severe, we can manage the major depression and suicidal tendencies to help these clients. In a scenario where the patient is deceased now, there's a burden that comes into play for the family, and there's issues of grief. So the community has to come into place as well to help manage the grief, and also respite care, which is just offer some form of relief for the clients. And then at level two, there's grief counseling and then management of mild to moderate depression and anxiety amongst the family members when this happens. As I've highlighted in these tables, I hope you've been following, is that mental health, like everything else, is a spectrum, and we need to be able to intervene at every critical point. Before someone starts treatment, as they're being treated, when they get ill, when they're getting better, mental health should always be on our minds. Next slide, please. So just to reemphasize what I was discussing earlier, we need to, because of the resource limited setting that we're in, what we are strong in is the community support programs that we need to strengthen. And once we have our population knowledgeable about mental health and why people can go for help, I feel like it will be easier to reduce severe cases and help our population as a whole. And then we can cascade it upwards to the primary healthcare services as well as specialist treatment when need arises.
All right, thank you, Dr. Chambwe, for that. We'll pause for another poll question. Allow me to launch the question. Right, so the question reads, with respect to ARV use, that is antiretroviral use in mental health, which of these is correct? Is it A, ARV's side effects can also include psychiatric symptoms? B, zidovudine and abacavir have been associated with mania and psychosis. Then C, efavirenz has been associated with mood changes and vivid dreams. And then D, dolutegravir has been linked to insomnia. Then E, all of the above. Okay, I'll read it again. So with respect to antiretroviral drug use in mental health, which of the following statements is correct? Is it A, antiretroviral drug side effects can also include psychiatric symptoms? B, zidovudine and abacavir have been associated with mania and psychosis? Then C, efavirenz has been associated with mood changes and vivid dreams. Then D, dolutegravir has been linked to insomnia. Then E, all of the above. Right, okay. So far we have less than 50% of the network responding to the poll. I would encourage the rest of the network to respond to the poll, and we see what is the correct stem. Is it A, is it B, is it C, D, or is it indeed all the statements that have been raised? So far the majority, right, so every option has got some responses except D so far, with the majority going for E. So, right, so I have more than 50% of the network responding to the poll. So allow me to end it within a few seconds and share the results. Right, so, okay, so the poll has ended, right? So there are the results. So we have the majority saying that E is actually the correct statement. So we'll see as the presentation goes, the correct responses. Right, so I'll hand over back to Dr. Chambwe to continue with the presentation.
Okay. Thank you very much, Doc. So for the next phase, we talk about the interaction between mental health and ARVs. I'm sure you remember this picture. So this part will focus on the biological aspects of the biopsychosocial model. So drug interactions, it talks about how the body interacts with the drugs and how the drugs interact with the bodies. And in mental health, especially with someone taking ARVs, that drug interactions that take place, that they affect somebody's well-being and also elicit some psychiatric symptoms. Next slide, please. So mental health, as we mentioned earlier, HIV and mental health have a bi-directional relationship. So can undermining health-seeking behaviors can reduce adherence, treatment, and lead to higher mortality if someone is infected with HIV. And also, HIV infection may lead to associated neurocognitive disorders. For example, dementia, something going through depression, and also anxiety. So some common prescribed antiretroviral medications can also result in neuropsychiatric side effects. For example, Zidovudine and Abacaba have been associated with mania and psychosis, whilst efavirenz gives mood swings as well as vivid dreams. And poor adherence to ART has been linked with efavirenz use in some settings, and also dolutegravir has also been associated with insomnia. And as we are managing these clients, whether they have a mental health disorder before being diagnosed or after being diagnosed, we need to know the drug that they're on and the drug-to-drug interaction, which the drugs that are already on will have with the ARVs. However, this is not in the scope of this presentation, but that's something that's important to consider as we see our clients. Next slide, please.
All right, so we'll pause for another poll. Okay, so the question reads, which of the following is true about CETA in people living with HIV? Which of the following is true about CETA in people living with HIV? Is it A, the common element treatment approach that is CETA is evidence-based system of care? Is it B, is effectively delivered by non-mental health professionals? Is it C, one provider can treat a wide variety of problems? Or is it D, CETA mainly uses cognitive behavioral therapy to treat clients? Or is it all of the above? I'll read it again. Which of the following is true about CETA in people living with HIV? So CETA is common elements treatment approach. Yes. Okay, so is it A, CETA is evidence-based system of care? B, is it CETA is effectively delivered by non-mental health professionals? C, one provider can treat a wide variety of problems? Or D, CETA mainly uses cognitive behavioral therapy to treat clients? Or is it E, all of the above? Okay. Right, so we have a few responses for all the options. The majority so far going for the last option. Still hold on a bit for at least most of our network to respond to the poll. Once we have the majority respond, then we'll end the poll. Okay, so far we have 73%, about 73% of the network feel that E is the correct response or option. Right, so we have at least 50% of the network have responded to the poll. So allow me at this point to end the poll and share the results. Right, so you can see that the majority have actually gone for E as the correct option. That is, CETA is evidence-based. Yes, it can be effectively delivered by non-mental health professionals, and one provider can treat a wide variety of problems, and it mainly uses cognitive behavioral therapy to treat clients. Right, so we'll see with the preceding slides which one is actually correct, or is it indeed all the options that are correct. So I'll hand over back to Dr. Chambwe to continue with the presentation.
Okay, thank you very much, Doc. So CETA, the common elements treatment approach. Okay, it's one of the methods that we use to treat our clients. It's scientifically proven modular, multi-problem transdiagnostic intervention, combining treatments for a range of mental health issues like trauma, depression, anxiety, substance abuse into one single mode. Next slide, please. So as you may be aware, usually when you have a client with a mental health disorder, it's usually not just one. For example, somebody that comes with depression most likely may have issues of substance abuse or alcohol abuse, or someone with anxiety may have issues of maybe past trauma, substance abuse, or depression as well. So the good thing about CETA is that we encompass and try and treat all these symptoms, look for them, and treat all of them at once, so that we can treat this patient holistically. The different modes of treatment that we use are varied, and the main one that we use is the cognitive behavioral therapy, but also engage cognitive coping, behavior activation, and also anxiety management and safety assessments and treatments are also done in these cases. So CETA care and treatment stage. So CETA can be used for someone HIV positive, for those that are negative and we think are at high risk. You can use it to reduce violence, mental health disorders, substance use, and risky behavior, all of which may be linked to poor adherence and retention. And we can also use one or two elements of CETA to help in the management of behaviors to increase adherence by incorporating positive rewards and increased buy-in of the program, thought changing, problem solving, as well as challenges. And can also help with difficult issues that come into play as we are treating our clients, like issues of disclosure. So this diagram simply illustrates the ultimate benefits of integrating mental health in patient care. So if we have a patient there that's screened, and then we commence mental health treatment, and the improvement that we expect to see is that the symptoms they subside, they might reduce in the use of the substance, and also learn to have stress coping mechanisms or interventions. And this will ultimately reduce HIV risky behavior, improve adherence to treatment, and also improve linkage and retention to care. So for those that are HIV positive, this will reduce the viral load and in turn have them suppressed, and then we can achieve U equals U. And then for those that are not HIV positive, they can also have the reduction in HIV transmission by taking care of themselves better. And this treatment is helpful in treating depression, PTSD. This is PTSD and also SUD, which improves adherence. So who can provide CETA? As we mentioned earlier before, with the wide base with the community, CETA is focused at community and primary healthcare level. So we don't need to have professionals to be trained in CETA. We can have lay providers with minimum education, preferably maybe grade 10 and above. They should be able to speak a local language. They should have passion for the community, generally good people, and with a good standing in the community. Should be able to dedicate time for CETA, and have organizational skills, responsible, and have basic knowledge of the use of computer and the phone, and also can provide them with a private space for them to conduct their sessions. So for the CETA approach, we can manage cases that range from being mild, or prevention for high-risk clients, also those with mild problems, and then moderate to severe problems. And they vary in sessions. For the mild cases, can be 3 to 5 sessions, while moderate to severe can go 8 up to 12 sessions. Session can be longer or shorter than an hour, and it also just depends on individual basis, and they can be at individual or group format. So as you can see from that pyramid there, CETA covers a wide range from prevention all the way up to treatment and recovery of the client, which I feel is effective to cover all the bases and ultimately help our clients. So just to reemphasize the importance of this diagram. So the benefits of integrating mental health screening and treatment in HIV care. When we screen our patients, we treat them, we monitor the patients as their symptoms are subsiding. We can get the positive outcomes that we need, can reduce, can treat depression, post-traumatic stress disorder, and substance use disorders, and improve adherence. Thank you very much for listening, and I'd like to acknowledge the help that I got from my colleagues, Dr. Dalao, the CIDAS team, the Johns Hopkins team, and the Ministry of Health team. Thank you very much.
All right, thank you very much, Dr. Chambwe, for that wonderful presentation. So at this point, before we go to our panel for some comments, I'm joined by Dr. Dalao here in the hub at UTH. Then we're also joined by Dr. Francisca Walia and Gabriel Lungu. So before we go to the experts for some comments, ask the network for any comments, questions you may have on the presentation. Our well-able panelists will be able to tackle them. So if you have a question, you can simply raise your hand and then we'll ask you to unmute and ask your question. So over to the network. I'll open the floor to the network for any questions, clarifications before we go to our panel of experts for the final comments after this didactic presentation. Then we'll move on to the case. So to the network, any questions, comments? All right, so if there are no hands raised, I'll go to the chat for questions in the chat. Okay, so I think we have one question so far in the chat. Right, so there's a question from Peter Singogo. Okay, how different is CETA from psychosocial counseling? How different is CETA from psychosocial counseling? Right, so probably from the hub, I'll ask Dr. Dalao if you can give a comment, or we'll start with Dr. Chikumbi Chambwe. How different is CETA from psychosocial counseling? Question from Peter Singogo.
All right. Thank you very much for that question. So the main difference between CETA and psychosocial counseling is more of a broad aspect. Whilst for CETA, like we mentioned earlier, it uses we use cognitive behavioral therapy to manage the different clients that we have, and it's not siloed as we have in psychosocial counseling, because psychosocial counseling, you have someone with depression, treat them with depression alone. Anxiety, you use the GAD to score them and treat them. But the difference that CETA is more holistic and it treats all these symptoms or disorders at once. Thank you.
All right, thank you for that, Dr. Chikumbi. There's another question in the chat from Yvonne Piri from Kapiri. Thank you, Yvonne, for that question. The question is, how does one get trained in CETA? How does one get trained in CETA?
Okay, thank you very much for that question. So with regards to the training, we're working with our colleagues at the Ministry of Health and Johns Hopkins to help roll out and increase the number of treatment supporters and counselors that can be trained in CETA. So that's being planned, and I think that will be rolled out in the near future, and it will be communicated through a platform such as this to the entire network. Thank you.
All right, great. And probably as a follow-up to that question, there is another one actually from Kawe again. How can one be eligible to offer CETA, and to whom can one reach out if they're interested in being trained or oriented? So to whom can they reach out if they are really interested to be trained in CETA?
Sorry, what's the first part again?
So the first part is more like the first question, but as an add-on, to whom do they reach out if they're interested in being trained in CETA?
Okay, so right now in Zambia, we're trying to create a system of having our own CETA counselors and CETA trainers of which we can be able to roll out and train. So once we roll it out, we're going to reach out to the facilities, and then from there, you'll pick out teams of people that you can see in your teams who be eligible and who be effective CETA providers. So we're simply rolling out now, and we'll advise when that time comes. Thank you.
All right, thank you, Dr. Chambwe. Actually, that even answers some of the questions that are there. When are you rolling out? So you're actually rolling it out now. Then there is another question from YK. I don't know where this is from, but the question is, what can be done to reduce those mental illnesses, especially those caused by drugs? Probably Dr. Naeem can take this one up. What really can be done? Just briefly, what can be done to reduce mental illness, especially those caused by drugs? What's your take on that, Dr. Delao?
Mental illness is caused by?
What can be done to reduce mental illness, especially that is caused by drugs?
Drugs. Okay. So with respect to drugs and alcohol, this is where the concept that Dr. Chambwe was talking about in the biopsychosocial model comes in. We need to be aware that many of us in the country are actually using drugs as a means of coping strategies with the day-to-day stresses that many are facing. So the answer to that is equally awareness and creating that level, one, understanding of what we have to do in the community level. We need to create those preventive messages, and we need to stop that, especially at adolescents and at the youth level. So with respect to mental health illnesses that are coming about due to substances, it's because we need to create more awareness, and we need to create this in terms of what are the do's and don'ts with respect to healthy, for instance, alcohol use, and also for illicit substances. But with respect to individuals that end up with substance use disorders, this is where, again, we need to create awareness that they can come through for help and support so that they can be treated and get the support that they need, and then they can, live healthy and better lives.
I want to add something. All right, thank you very much. So any additions, Dr. Chikumbi?
Yes, in addition to that, as for the rollout of CETA, I would like to just mention to the network that we have some CETA sites that are functioning in Western Province, Southern Province, Lusaka Province, and Eastern Province. So our plan is to just strengthen those sites and improve capacity of the councillors there. And then we're going to roll it out to the rest of the country, God willing, the next few months or years. But we feel that CETA is very effective, and I think it will help a great deal of people, given our current situation as a country and the terrain that we have, the number of healthcare workers that we have. It will be a very good program, a good tool we can use to reach out to our clients that need these services. Thank you.
All right, thank you. And just as an add-on, probably there's a question in the chat from Dr. Chambwe as well. Is there a separate pediatric component in CETA, or is it encompassing everyone, including the pediatric population?
Okay, very good question, Doc. So right now, we don't have any pediatric component for CETA, but we're hoping to have that added on as time goes on. So right now, CETA mainly focused on adolescents all the way up to adults, but we'll need a pediatric component that will hopefully be commenced soon.
Yeah. All right. Okay. Thank you. Thank you for that. So just in the interest of time, I think before we move on to the case by Kabwata Urban, just a few comments under 2 minutes or so from our panelists. Dr. Francisca Walia, if you are on the call, any comments on that interaction between HIV and mental illness? And also there is a question that has been asked in the chat to say, what are the main causes of depression? Probably as you come in, as you give your comments, Dr. Walia, you can also just briefly highlight the main causes of depression in Zambia. Over to you, Dr. Walia.
Thank you, Dr. Matibula. I think CETA is a good initiative and approach, and I think even for us as mental health experts, we welcome it. And it's got a great potential to reach so many people. If we've paid attention to Dr. Chambwe's presentation, we will appreciate that various cadres can participate in that. So meaning it gives us the opportunity to reach many people, and that will translate into many people having a healthy a healthy mental health, mental status. And further, linking it to HIV, we can appreciate that we have a large percentage of our population who are infected with HIV or affected by HIV. So CETA is very welcome, and we see people experiencing in practice a lot of mental health issues and challenges related to the HIV status. So I think CETA is very welcome to improve the mental health of our patients living with HIV. Then to answer on depression, if I followed well, it's the causes of depression.
It's the main causes of depression. Just briefly mention some of them.
Yeah, so HIV, the topic on the table, on the floor today, is one major contributing factor to presentation of depression. Because of course, we will realize that a lot of people might not take that diagnosis very well, and because of its chronicity. And it's not only unique to HIV, but depression is also common in a number of individuals who present with chronic mental health or physical conditions. Then further, alcohol and substance abuse has been seen to be a major contributor as well to presentations of depression. Actually, for that, it's usually a vicious cycle. It could be the alcohol causing depression or depression, which is leading to alcohol consumption. Then commonly as well, relationships, relational interactions. I think we've seen an increased contribution to the presentation of depression due to different relational interactions. And in the recent, with COVID-19 as well, bringing in many other factors from relational to financial stresses, that has also caused a lot of presentation of depression. Just a few to mention, those are some. Thank you.
Thank you, Dr. Walia, for those comments. We are also joined by Dr. Seluke as our panelist. So Dr. Seluke, we are welcome. Just brief comments concerning the topic for today, leveraging on CETA to improve clinical outcomes in people living with HIV. Just under a minute or so, your comments after the presentation. So I'll allow Mr. Gabriel Lungu to give a few comments, and then Dr. Seluke, and then we can move on to the case. Mr. Gabriel Lungu, if you are still on the call, over to you. Your comments on the topic for today.
Thanks so much, and thanks so much to Dr. Chambwe for the nice presentation. Yes, CETA has come as really a remedy to most of the mental health issues or issues surrounding people living with HIV. As you may be aware that HIV affects a person almost in totality as presented. Biologically, the effects of the ARVs themselves, they can have some impact on the brain structure and cause some behavioral changes. And also, if you look at the diagnosis itself, as Dr. Wadi has mentioned, you'll find that a person may not really take the diagnosis so lightly, because it's a heavy burden to be diagnosed with the HIV, and that as well may send someone into self-stigma and eventually developing depression. And if you look at the social impact, not only the person who is diagnosed with HIV also suffer the impact of the diagnosis, but if people, again, the circles surrounding the patient, these includes the relatives also, they may feel the sense of being in the vicious cycle of the person who has been diagnosed with HIV. And to a person, again, who's on ARVs, it's not a simple issue to live with, to live on drugs for the rest of their lives on the ARVs. That has a huge psychological impact, because they may anticipate how long would they live just with a life of taking ARVs. And if you look at the targets in which CETA wants to impact is to strengthen the coping skills in an individual and also bring everyone on board, including the family, the community, in the betterment of a person who might be struggling with the personal and all those community impact. So CETA really brings everyone on board to bring the mental health issues or assist a person who is suffering from HIV. Thank you.
Thank you, Mr. Lungu, for that, for those comments. So Dr. Seluke, any comments? And as you come in, there's also some questions in the chat. Can CETA be scaled up to the general public, especially those with suicide cases? And does it have a nutritional component? Probably as you give your comments, Dr. Nseleke, you can also comment on those two questions. Can it be scaled up to the general public? And does CETA have a nutritional component? Over to you, Dr. Mwene Nseleke.
Thank you very much, my fellow panelists. It's been a pleasure to be with you. I joined you a bit late. I was in another meeting. So I think as looking at what CETA is able to do and our desire to bring primary health care as close to the people as possible, we are looking at the aspect where, you know, at primary level, mental health challenges are right there in the communities. And looking at what CETA is able to do in terms of the modular structures, training component that is there, and intervention that they have actually done in the communities, its effectiveness is undoubtedly true. And this is what we are looking towards as a ministry. So in my submission, among other what many people have submitted, in terms of what we are looking at, reaching out mental health problems in the primary community, primary level. And this is what CETA is able to do right across the disease entities. You look at it also from the HIV component, all those people who are stressed by one reason or the other, it is key in this particular area. So I think that would be my submission for now. In terms of scaling to the community, with availability of resources in terms of intervention, it has proven that in a number of individuals in the community, they can be assisted. So CETA can be able to play a role at community level, depending at what level is being used. Thank you very much. I submit. I think the other questions I will surrender to the other panelists to comment. Thank you.
All right, thank you very much. Please stay with us and join us for the collaborative discussions as we have the breakout session after the case is presented. So at this point, Kabwata Urban Health Center, are you ready to present the case? So as you prepare, I'll ask Dr. Dalao to just comment on some of those questions that were there. So Kabwata, are you on the call and are you ready to present the case? Just briefly in 5 minutes to present the case, and then we can proceed with the discussion. So Kabwata, are you ready with the case?
Yes, we are ready. Maybe we can be up to sharing our screen.
Yes, you can share from your end, so you can share the screen. So as you share, Dr. Dalao, can you come in with a few comments on the questions that were asked earlier?
Yes, so the question is that can we incorporate nutrition into the CETA approach, and also asking if we can take CETA out in the communities outside the HIV population. The answer to both those questions is yes, because when you look at the CETA approach, we're talking about cognitive behavioral therapy. Cognitive behavioral therapy simply means you are looking at thought processes, you are looking at behaviors, and you're looking at emotions. So when you apply all those, and if you find an individual that has a challenge with the nutritional status, you can actually incorporate that into the practice. And as with respect to communities, yes, CETA is not just applicable to people living with HIV, but it can be applied to all individuals with or without HIV. This is why, as Dr. Chambwe's presentation alluded to, even individuals that are not positive for HIV, but maybe in high-risk communities, can actually be beneficial to CETA. But just to add one more thing, as we're talking about CETA, it's an important thing because, you know, we have syndromic management of a lot of physical conditions in our practice. CETA is one such thing that can allow us to pick up mental health symptoms and signs early on, possibly treat them, but even if we are not able to treat them with the CETA approach, they can be triggered into specialist tertiary care, as Dr. Chikumbi mentioned in the pyramid. So to answer to that question, yes, nutrition can be improved, yes, communities can be incorporated, and yes to HIV approach and CETA.
All right, great. Thank you very much, Dr. Dalao, for those comments. So at this point, we'll now go into the case, a very brief case from Kabwata Urban Health Center. So James CHIPO, you can go ahead with the case. So after that, we'll proceed to questions, and then we'll break off into collaborative discussion with the various panelists. So Kabwata, you can go ahead. with the case presentation. Thank you.
Thank you very much. Good afternoon, everyone. This is James from Kabwata presenting a case. So ours is a case of LN, male 33 years, was brought to the facility on the 4th of September 2021 by the parents. The patient complained of hearing voices, seeing things and people, fever, body weakness for the past 3 weeks. The patient has been having the above symptoms, but were not occurring often, but symptoms became worse in the last week with episodes occurring every day. There was also a history of the client starting the day with a cigarette and drugs such as marijuana every day. Then there was also a history that was taken from the relatives of seeing him talking to himself, laughing alone and pointing at imaginary things. He was also aggressive and less stressed. Patient was given pre and post-test counseling by the parents, suggested that disclosure should not be done, but should be given time for them to do so, as there was in fear of him getting aggressive, as there was such a history. The patient tested positive on the same day, which was 4th September 2021, and was initiated on ART, which was TOD, septrin, and INH was also given. Baseline labs were not done as the patient did not allow to be bled. Only managed to do RBS, RPR, and RDT. Then the client was referred to UTH for further management, but declined to say he was okay and needed no help. The client came for clinical appointment on the 1st of October, and disclosure was done, but the client refused and accused the health workers and relatives of bewitching him. Information received was that the patient was taking the drugs, though he was missing on some days. Thereafter, only batch collection was done as the client refused to come to the facility. Current information taken from the parent was that the patient is currently admitted as Chainama Mental Hospital. On past medical history, RVD reactive in 2021, also a drug-induced psychosis in 2020, which was managed and recovered. There was no history of hypertension, DM, asthma, and epilepsy. Social history, the client is divorced with a child, businessman, alcoholic, at least 10 bottles in a week, smokes at least 4 cigarettes in a day, and also abuses drugs like marijuana and cocaine. On physical examination, the temperature was 36.8, height 172 centimeters, the BP was 124/86, pulse was 72, weight was 62 kg. On examination, general condition was physically stable, all the systems were normal. Mean mental state examination, the patient scored 28 out of 30. Then on mental state examination, the patient was conscious, sleep rest, anxious, oriented to time and place, not confused. And the patient was also able to remember past experience, both short and long term. Was also very attentive and interactive. Perception was intact. No audible or visual hallucinations was noted. Then our clinical timeline, we only managed to do RPR, which was negative. RBS was 5.4, and RD2 for Maria was also negative. The patient is on TOD. Our questions are, the first one is, what are the main issues that need to be addressed in this client? Thank you. Then our second question is, what other approach could we have used to help the client, inclusive of both investigation and management? And our third question is, how best can the client benefit from CETA services, considering that his adherence is compromised? Thank you. I submit.
Okay, thank you very much, James, for that case presentation. So I'll invite the network at this point for any clarifying questions or clarifications on the case. Any more information that you may need. It's basically a 33-year-old male, HIV positive, who had issues with drug use and alcohol, didn't have insight on his illness. He presented with psychiatric illness. And these are the questions that Kabwata Health Center has. What are the main issues that need to be addressed in this client, and what other approach could they have taken to help the client, inclusive of investigations and also the management? Because if you notice from the case, this is a client who didn't accept taking the medication despite that diagnosis being made. And how best can the client really benefit from CETA services? considering that his adherence was compromised. So any clarifications from the network, you can do so by raising your hand, and then we'll ask you to unmute and then ask your questions or comments for the case presenter to clarify. Over to the network, if there are any questions or clarifications about this case. Okay, so far there is no question in the chat or hand raised, so I'll go to the panelists if they have any clarifications over the case before we can ask them to comment. Okay, so before we move to the panelists, there is a hand that is raised by Mutondo. Okay, so Mutondo, you can unmute and go ahead and ask your question or clarification. Mutondo, you can go ahead.
Sorry, I was with the client. I missed out on the initial history of the client. I'm not sure if this client was initially screened for any mental illnesses at first visit. Is it possible that you can share that slide again? Thank you.
All right, thank you, Mutondo, for that. James, if you could beam the slide on the first slide on the history presentation. Was the client screened for any mental illness before this?
So this is the patient that had history of drug-induced psychosis previous in 2020 and was managed and he recovered.
All right, thank you. Some more hands raised. Manfred Lupia and Chipembe Mission in that order. So Manfred Lupia, if you can unmute and ask your question, and then followed by Chipembe Mission, you can unmute and ask your question in that order. Manfred Lupia.
Yes, good afternoon, Doc.
Good afternoon. Go ahead with your.
Yes, so my comments are based on the issues which were supposed to be attended to earlier on. Because from the onset, you could see that this patient wasn't ready mentally. He came in with the auditory and visual hallucinations, and then from there they quickly tested. And I don't know what was done during the pre-test and post-test counseling. The disclosure counseling wasn't done as well. So from that point, we missed it, and mental screening wasn't also done. So I feel this patient would have benefited more if he was prepared initially, and then treatment followed up. So this calls for concern in terms of retention and also adherence issues which came in later on. I submit.
All right, thank you, Manfred, for that comment. Chipembe Mission, your comment or question? I've lost Chipembe Mission, but in the interest of time, colleagues, we can probably break out into the smaller groups to actually discuss the case with the different experts that we have on the panel. We have Dr. Francisca Walia, we have Mr. Gabriel Lungu and Dr. Mwene Seluke. So then in the main hub, we have Dr. Naim Dalal in UTH. So we'll break up into different hubs. We'll have the central hub, where we'll have Dr. Naim Dalal and Dr. Chambwe. Then the Lusaka hub, we'll have Dr. Angel Chira, she's on the call. And then the Eastern hub, we'll have Dr. Francisca Walia, and the Southern hub, we'll have Dr. Mwene Seluke, and then the Western Province hub, we'll have Mr. Gabriel Lungu. So I'll ask IT to just make a small announcement on how to go about the breakout session. So we'll have the breakout sessions for an expert collaborative discussion for about 10 minutes, and then we'll come back with a recommendation. So IT, guide us on how we break out into these smaller groups.
Okay, thank you so much. So dear network, please note that as we break out into the various rooms, you can self-assign yourself to a room of your preference. So you will receive a prompt once we click open breakout rooms, and then you can self-assign yourself to the room you prefer to be in. So please note that a prompt will appear on your screen, whether it's on your mobile device or your computer. So please be aware of that prompt to be a small window. You click on it, and then you'll be able to choose your room. Thank you so much.
All right, thank you, IP, for that announcement. So as you heard, network, so just wait for that prompt, and then you can assign to the smaller groups for that collaborative discussion on the case with the panelists that we have. Thank you and enjoy the discussions. We'll be back after 10 minutes for the final wrap up and recommendations. Thank you. All right, welcome back, Network. I hope everyone had very fruitful discussions in the various breakout rooms. We are very hopeful that we'll have recommendations coming from the various groups, from the coordinators actually in the various provinces. You should be able to send out the recommendations on this case to the HIV/TB ECHO coordinator, ETA. So at this point, I think we are coming to the end of the program, but before we can close, I'll ask Dr. Dalao to just give a brief summary of our presentation for today, and then we'll close after the summary from Dr. Dalao. Just a reminder, Network, again, this Thursday, before we go to the summary, this Thursday we have a presentation on advanced HIV disease. We'll be looking at recurrent cryptococcal meningitis. That is this Thursday, and then next week on this same fora, we'll look at active case finding in TB. So just as a summary, Dr. Dalao, over to you.
All right, thank you, Dr. Matibula, and well done. Good job, Dr. Chikumbi Chambwe, in bringing out the objectives. So based off the poll questions, yes, HIV, people living with HIV do seek mental health services, and they are actually one of the leading admissions and inpatient reviews that we see all across the country. The second objective, key strategies. One of the key strategies is actually embedding mental health services and screening pre-art as well as during treatment and support throughout the HIV journey. And further to that, mental health and antiretroviral drugs, we need to understand the drug-drug interactions, and certain antiretroviral drugs can actually predispose to mental health symptoms. But also HIV, the virus itself, can go to the brain and lead to opportunistic infections and lead to psychiatric symptoms. So we really need to investigate patients and then treat those underlying conditions, because in HIV psychiatry, if we have to give medication, we're actually treating symptomatically rather than actually the underlying mental health disorder. So please understand that, and the key is actually adherence and U equals U. Then, of course, finally, the common elements treatment approach, which is the topic of today, is actually a game changer, in particular for people living with HIV, because we will be able to holistically treat them, but also identify certain stresses that they are dealing with that may be preventing the adherence patterns. So with that said, well done once again, Dr. Chambwe, and thank you so much for the opportunity.
All right, thank you, Dr. Dalao, for that. Once again, Dr. Chambwe, thank you for the presentation. And thank you to our experts, the panelists who joined for today, Mr. Gabriel Lungu, Dr. Francisca Walia, Dr. Mwene and Seluke, thank you very much. I would like to remind the network, kindly remember to register before you log out, register for this session. And a reminder for Thursday's session, we'll be looking at recurrent cryptococcal meningitis under the advanced HIV disease ECHO. And then next week, we'll look at active TB case finding. Thank you very much to the network for joining in this session. At this point, we've come to the end of the session, and have a good afternoon. From us in the hub at UTH, it's bye-bye for now. Please remember to register for the session. Thank you.